Thanks. Moving on from what have been quite informative talks with lots of evidence, I'm going to talk about something that has no great evidence and mine and Mike's personal thoughts on this. We've talked about it before. A few of you probably heard this talk or parts of it. And it's more of going back to basic science, trying to talk about why things don't work, how we might get them to work. And Brett will talk more about trying to get big data on this to work out whether we can do better. So, yes, the first description was around about 2004, 2005 in the endocrinology journals, and I'm sure none of us read it. So about 10 years after the first orthopaedic journal published on atypical femoral fractures, we're crap. 30% non-union rate, 30 to 40% complication rate in these groups across the board in all the studies, and nothing has really changed in that time. You go back to the mid-2000s, this was about the complication rate. You go to this paper published at the end of last year, just the same. So briefly on our experience, I don't want to dwell too much on this. I've talked about this before. Our incidence matches the worldwide figures, 1.1 per thousand per annum of people on bisphosphonates. We had a quick look at 12 of our fractures a couple of years ago. Purely the subtrochanteric fractures, not going into the atypical fractures further down in the femur, down by the isthmus, the distal femur. I think they're a different beast, so we just looked at the proximal femoral fractures. And we had a 42% revision rate in an elderly population, which we don't accept in hip fractures. So why should we accept it in these fractures? And of those 12 fractures, only 2 of them, at up to 2 years follow-up, had actually gone on to complete union. And by complete union, I mean the lateral side and the medial side, the anterior side and the posterior side, had all united radiographically at 2 years, 2 fractures. Some of them hadn't been revised, they hadn't failed, they hadn't fully healed, but the patients were happy. So it's not a bad result, but it's not necessarily a good result. And I'm going to show you a series of x-rays that I'm sure you can all relate to, that you've all seen, that are embarrassing. They're not great, but we've all seen that, and then that, and then that, and then someone comes along and thinks, oh, I know, we do that, and then that, and we think, aha, we'll do that. You'll see by the cement beads in there that it wasn't that uncomplicated. That person did eventually heal, but that's a lot of operations in what in our series are an average of an ASA 3.5 group with multiple comorbidities. And particularly when I looked at the revisions that we did, the ones that were revised often went on and had another revision for another periprosthetic, another breakage, or infection. So I want to get it right first time, as we all do. So going back to basics, what is the problem? Is it the patient? Can we blame the patient completely? Can we wash our hands of it and say, we're fantastic, the patient's doing it wrong? Are we doing it badly? Are the implants not designed very well? Are the implants breaking on us because of poor manufacturing? Or is it just the drugs the patients are on have messed up their bone and there's nothing we can do about it? And I think in all honesty, it comes down to every single one of those factors. And it boils down, like all fractures that are problematic, it's a problem with biology and it's a problem with mechanics. Simple. So we know what the problem is. They've got bad biology and they've got bad mechanics. But what can we do about it? In a nutshell, these patients are slowly fracturing. We know that. We know this isn't an acute fracture. Most of these patients will come in with a history of prodromal pain. A lot of them, when you go into their history, will talk about the fact that they had pain, they fell slowly to the floor. They didn't fall and fracture, they fractured and fell. And in a nutshell, they have progressive tension failure, intervarus, secondary to poor biology. Some papers have said these are patients who have varus femurs, they're on bisphosphonates. Because they're varus femur and the bisphosphonates, they end up fracturing. No one's really gone back, well, no one can go back and look at those x-rays beforehand. Have they always had varus femurs? Forever in their life they've had varus femurs? Or is it just that they've become varus over time because of their progressive failure? So, biology and mechanics. Biology, we can't change their osteoclast dysfunction. They're on bisphosphonates, their osteoclasts don't work. There are very few papers, but some papers that support that their osteoclast will never work again. You can stop the bisphosphonates as long as you want. There was a histological analysis from Japan a few years ago where they were looking at iliac crest biopsies in patients after stopping bisphosphonates, and they never really got working osteoclasts again. So we can't change the biology. The drugs are in there, we can stop them, we should stop them when they come in with the fracture, but I don't think it actually changes their bone biology. But we can change the mechanics. And we all know the first principle, the first cardinal rule of femoral nailing is thou shalt not nail the femur in varus. We're all taught that on day one, don't do it. But they're in varus before they broke. So this is an attempt at reconstructing a femur radiographically to see what position it was probably in before they fractured, and they're in varus before they break. So if we don't want to nail it in varus, but they're already in varus when they're reduced, that's a little bit difficult. So we had to think, one of those usual late night thoughts, I'm going to come up with a solution to this, what can I do? We've already worked out we can't really change the biology, so try and change the mechanics. So get them out of varus, put them into valgus. A very old teaching, but probably still applies. And our thoughts was to do that with the valgus subtrochosteotomy. Through the fracture site, they've already done it. All you've got to do is tidy that up into a bit of valgus. The advantage of that as well, in my view, is it takes away that sclerotic lateral cortex, which has been fracturing for months or years and hasn't healed. The lateral side isn't an acute fracture. So by excising the lateral wall, not only do you get them into valgus, but you also make that bone bleed. You don't need the osteoclast to function as much. You just have some of the osteoblasts working in the blood. And try and change the mechanics. So it's a progressive tension failure. Even if you put the femur in valgus, there are still tension forces on the lateral surface. So try and compress the lateral surface. Basic principles of orthopaedic fixation, tension band constructs. So get them into valgus, tension band them, so that when they stand on it, you're reducing the potential tension forces, but what you're trying to do is turn those into compressive forces across the whole femur. Doing that with a small fragment plate over a dynamically locked nail. A statically locked nail won't give you that tension band construct. And hopefully, with my lovely handcrafted pictures, you go from that with a centre of rotation of the nail, with tension laterally, compression medially, fingers crossed, into that. Moving your centre of rotation of your construct over to the plate, so compressing both surfaces. And fingers crossed that would allow them to heal. Based on no patient data, based on no wonderful scientific information, but basic principles in the thought process of what we're currently doing and have been doing for a decade doesn't work. So why not try to do something differently? We've done this a couple of times, and practically speaking, it is quite a steep learning curve. I do mine in a lateral position. I find it easier. The approach is easier. Everything's sitting in front of you. Do your osteotomy with a saw. It's amazingly hard bone, and an osteotome just doesn't cut it. I use a small fragment plate. It doesn't get in the way. You can go bicortical with the screws. You can still get your nail easily past it. And just again, mechanically speaking, moving a troch entry nail into the piriformis fossa should, in theory, give you about 10 degrees of valgus in the subtroch region. And it's going to help keep them out of that varus position. And it's not that difficult once you try it a few times. I won't show her next set of x-rays. It looks good. It didn't end well. As I said, a steep learning curve. And what you can see on her is if you measure her other femur, she's probably about 4 or 5 degrees varus on that side. Whether that is her natural position, whether that is something she's developed over the years of being osteoporotic and on bisphosphonates, I don't know. And on the side we fixed, we've got her into about 7 degrees of valgus, so about 15-degree change of her physiological varus into produced valgus. A couple more tips from our learning curve. Excise more than you think. That was a tiny little lady. She's lovely. She's my favourite patient. I put her through hell. She is tiny. She's about this tall. And I excised a centimetre, or maybe 11, 12 millimetres from her femur. And I probably still could have gone a little bit further. So you do take more than you think you need. You can always take more, but you often need to take quite a bit. Leave the plate on. You're going to lose that tension band construct if you take the plate back off. It's a great reduction tool, as we know from adjuvant plating around nailing. But leave it on. Changes the mechanics. It changes that tension force into a compression force. And you can see I used a recon nail in her. She was very small. Don't use a recon nail. There is a point of weakness where that other oblique screw should go. And she failed at 6 weeks and 1 day. We had a lovely x-ray at 6 weeks. 18 hours later, the nail had broken. And good luck. They're difficult fractures. We haven't got it right yet. This is just an idea. I'd love other people to start doing it. Brett will talk tomorrow about trying to get big data on these to see whether this does work. I don't know if it works, but I know what I'm currently doing doesn't. And if that doesn't work, jump to something else. If you do absolutely everything on day one to make a fracture heal and it doesn't heal, it doesn't want to heal. And repeatedly going back in there is probably not going to make it heal if you've done a very good job the first time. Don't put these people through multiple operations with increased risk of infection if that's where they're probably going to end up. So if you do it as much as you can on day one and it doesn't work, seriously consider that being your second operation. If duct tape doesn't work, you're not using enough duct tape. Any questions? We can move on afterwards.